So the talk for the next speaker will be from the Department of Anatomical Pathology, and the topic is on the 2022 WHO novelties of cancer pathology for urologists, and the talk will be given by Dr. De Stadler. If you're ready to De Stadler, you can start. Thanks.
Great, thank you. Can you hear me and see my screen?
We can hear you very well. Thanks so much.
Great, thank you. Thanks for the opportunity to speak on this topic. So just a brief background about myself. I'm a junior consultant in the Division of Anatomical Pathology with an interest in uropathology and liver pathology. And the topic for today that I was given is the 2022 WHO novelties of cancer pathology for urologists. So this is a fairly broad topic, and I'm going to try and cover it as succinctly as possible. So just up front, these are the references that I used along with the 2022 so-called Blue Book. So these articles all reference the so-called Blue Book, which is essentially a classification of urinary and male genital tumors, which was published by the International Agency for Cancer on Research. And the current 2022 revision is the 5th edition of this Blue Book, which provides a comprehensive update on terminology, epidemiology, pathogenesis, histopathology, diagnostic molecular pathology, as well as prognostic and predictive progress in genitourinary tumors. So I'm going to be covering 3 different organs, focusing on kidney, prostate, and bladder, including the different topics listed on the right. I'm not going to discuss testis, penis, and scrotum today. It's a very small chapter on updates. Most of the entities have remained the same. And if you're looking for an additional resource, this Euro webinar on the left is particularly helpful from 3 global specialists in uropathology. So jumping right in to kidney. So just a brief introduction to the changes within the WHO 5th edition. Morphology still remains the foundation for renal tumor classification despite advances in molecular pathology. However, this classification system is stratified. So initially, when we would receive a biopsy or an excision, we would try and look at the morphology, and the predominant morphology would guide us to a diagnosis. So classic entities such as a clear cell renal cell carcinoma could still be diagnosed on morphology. Other things which assist us in diagnosis include the location of the tumor, background renal disease, and resemblance to embryonic tissue. That molecular profile has become increasingly important in the diagnosis of kidney tumors. And as we can see here, the 5th edition lists 7 molecularly defined renal carcinomas which cannot be diagnosed without ancillary investigations. And I'm going to be speaking about a novel entity called the ALK rearranged renal cell carcinoma. So this, in the 4th edition, was an emerging entity, but it's now been included in the 5th edition as a distinct entity. These are sporadic solitary tumors which might have been previously lumped together with renal medullary or collecting duct carcinomas because of their more high-grade morphology and often oncocytic cells. On the top right, you can see a micrograph with eosinophilic or pink vacuolated cells, which are often present in these tumors. They present with a broad age range, typically affecting males more commonly, and they can also present in the pediatric and adolescent population. There are different ALK rearrangements with the VCL and TMP3 ALK fusions predominating in the younger age groups. For this diagnosis, it's mandatory to either have ALK immunohistochemistry and or FISH analysis available for the diagnosis. So fortunately, in our lab, we do have the immunohistochemistry for ALK, so we can apply this to tumors in which we are suspecting this diagnosis. On the right, at the bottom, you can see the fluorescent in situ hybridization in cells. So we usually have 2 signals per cell, and this is a FISH break-apart probe. So if the 2 different signals are fused, that's normal. So yellow signal for red and green overlapping would be a normal non-rearranged ALK gene. Whereas when we have splitting of the probes into red and green, that indicates that we've had an ALK rearrangement. And the significance of this diagnosis is that there's therapy available for these individuals, specifically targeting ALK, for example, alectinib. So it's important to try and diagnose these entities. All right, then there's been a few novel nomenclature changes in the 5th edition. Notably, clear cell papillary renal cell carcinoma has been changed to tumor. This is because it's a relatively indolent neoplasm. And then TCEB1, the gene, is now known as ELOC. And fumarate hydratase deficient RCC is a new term, which is an umbrella term for a group of lesions characterized by FH mutations. And then RCC unclassified has been changed to renal cell carcinoma not otherwise specified. And this is a heterogeneous group of lesions, which typically has a worse prognosis than clear cell renal cell carcinoma. So just briefly on these changes, like I mentioned, clear cell papillary renal cell tumor is indolent with very rare reports of metastasis. And so the term carcinoma has been dropped from the latest 5th edition. ELOC is the new name for this mutated RCC. It's known as elongin C, the gene, and hence the name change. These are clear cell tumors, not to be confused with clear cell renal cell carcinoma. They do have clear cell morphology. They do express carbonic anhydrase 9, which is an immunohistochemical stain we can do. But they are unique in that they have these thick fibromuscular bands which transect through the tumor. And if one had molecular available for ELOC, which we don't, then you could identify a hotspot mutation. These were important to recognize because they were initially thought to be non-aggressive tumors with a better prognosis than clear cell renal cell carcinoma. However, there has been emerging data that aggressive subtypes are around in case reports. So this might be better defined in the future. And then I mentioned that fumarate hydratase deficient RCC is the preferred term to the old hereditary leiomyomatosis and RCC syndrome associated RCC, which is quite a mouthful. This still exists, but it's also noted that tumors can be sporadic, arising from acquired mutations rather than germline mutations in FH. And so the term for this group has changed. Individuals with germline mutations often present with cutaneous and uterine, if they're female, leiomyomas, and uncommonly leiomyosarcomas. But up to a third can present with renal cell carcinomas. And these were traditionally lumped together in the old type 2 papillary RCC, which we are going to discuss shortly. So this has since been separated from that group as we've come to recognize that they share a unique genetic aberration and that we can stain for it with surrogate markers. The morphology is noted to be heterogeneous, but as you can see on the right micrograph, these tumors often are oncocytic or pink, and they have large nuclei with these prominent inclusion-like eosinophilic nucleoli with a surrounding halo, which mimic viral infections. So that would be a clue to test for it, amongst other things. And at the bottom right, we can do immunohistochemistry for FH. On the left, the blue staining indicates an absence of a protein by immunohistochemistry, so FH deficient. Or we have a marker which is a surrogate to SC, which we could use. Well, we don't have it in our lab, but it is available globally. And that would be a positive expression, interpreted as positive for diagnosis. And the relevance of this is that these tumors are aggressive. Despite being very small, they metastasize early. Okay, then I mentioned there's been a change in papillary RCC. So it is no longer recommended in the 5th edition that we categorize or subcategorize papillary RCC. So in the 4th edition, it was subcategorized into type 1, which you can see on the top right, and type 2. Type 1 being a much more basophilic or blue appearing tumor on low power because the cells are relatively small, they're cuboidal, and they have basophilic cytoplasm, often with interspersed foamy macrophages and calcifications. Type 2 was traditionally more eosinophilic and had large nuclei, but also a range of other morphologies. And I've copied a picture here of the FH deficient RCC, because this used to be lumped together in this category, along with a whole host of other tumors which have since been molecularly defined and therefore removed from the old type 2 papillary RCC. So as a result, this group has narrowed down, and it's now not recommended that we subcategorize papillary RCC. They share the same immunohistochemical profile, although they are still a heterogeneous group of lesions. They also include in the latest edition a number of novel entities which are emerging. So these entities include thyroid-like RCC and the ones I've listed here, biphasic squamous, alveolar, etc. In the next edition, these will very likely become unique defined entities, but for now they are just considered emerging entities, and they are placed as patterns under the category of papillary RCC. Also under the category of papillary RCC is a pattern of papillary renal neoplasm with reverse polarity, as depicted on the right. This is not a subtype, but will very likely in the future become a distinct entity as we gain more information and data about it. It's characterized by thin branching papillae with a low-grade appearance. It's oncocytic, so pink, and the nuclei are polarized away from the basement membrane, something we call reverse polarity. They have unique immunohistochemical and molecular aberrations. So they're positive for GATA3, which we know is often positive in our urothelial carcinomas. So this is a useful marker which we do have. And they often harbor KRAS mutations. However, there's some controversy about whether to split them from papillary RCC because they share chromosome 7 and 17 gains and chromosome Y loss. So for now, they are not a distinct entity. For now, they are grouped together with papillary RCC. And then a new category in the 5th edition is that of other oncocytic tumors of the kidney. So traditionally for oncocytic tumors, we are very aware of oncocytoma and chromophore RCC, which can have sometimes overlapping morphology, making them very difficult tumors to classify. And now this emerging group of other oncocytic tumors makes it easier to not try and box a tumor into one of those two categories. So this group of other is heterogeneous. It includes these 4 tumors at the bottom that I've listed. They all share this pink low power appearance, and they're also all low grade. So they include oncocytic tumor NOS, eosinophilic vacuolated tumor, also known as high grade oncocytic tumor or HOT, Birt-Hogg-Dubé syndrome related tumor, and low grade oncocytic tumor, also known as LOT. And these are novel entities. I'm not going to go into them just in view of time, but just to be aware that they do exist. So if we do see them in the reports coming up, one can refer to this chapter in the 5th edition. Then the 5th edition of the WHO also just touches on grading. And just to note that grading is still recommended for clear cell renal cell carcinoma and papillary renal cell carcinoma, but there are limitations. It's not necessarily advocated for other tumors, but can be useful in the case of SDH deficient RCC and the ones I've listed here. Importantly, it's not required for select tumors. So we know that collecting duct and medullary carcinomas are inherently aggressive tumors, and therefore grading them is not required. It can also be potentially misleading in certain tumors which have a high nuclear grade but indolent behavior, including the eosinophilic solid and cystic RCC, which I'm going to talk about as a novel entity. Some tumors, especially the novel entities like ALK-rearranged RCC, have limited data available. So we can watch the space in the next edition, and it may not be useful in a chromophobe RCC to grade. Okay, so I mentioned we talk about this novel entity, eosinophilic solid and cystic RCC. It's now been accepted as a distinct entity rather than an emerging entity. These lesions are sporadic, solitary, and they're typically small with an indolent course. They are more common in young females and may be seen in association with tuberous sclerosis due to aberrations in the mTOR pathway, including mutations in tuberous sclerosis gene 1 and 2. The importance is not only in recognizing them because they are typically more indolent, but also because there are clinical trials which show promise in targeting the mTOR pathway for treatment. And we've had cases here in our own division. So this was an article published last year based on 2 tumors that were seen. So you can go and have a look at that. And then not just a month ago, we received a 3rd case of a 55-year-old female with hypertension who had a right-sided renal mass, clinically a carcinoma, T2A, which underwent partial nephrectomy. This tumor was unique in that it was fairly large compared to the case reports. So 10 centimeters in greatest dimension. It had a solid and cystic cut surface with the solid areas appearing yellow or tan. So we can see where the name is derived from. The tumor's eosinophilic on low power or pink. And on the left, you can see the solid component. And on the right, you can see the cystic component. And on higher magnification, we can see that the cells protruding into the cystic lumen at the top appear hobnailed. This is a characteristic feature. And the interstitium is infiltrated by the same lesional cells, which have this basophilic or blue stippling, which has been likened to leishmania, infectious organisms, which can look similar. And you have these eosinophilic inclusions. You also have foamy macrophages interspersed. This is not unique to this tumor, but it's a helpful clue. We've also seen them in the papillary RCCs. And then they also have scattered dystrophic calcification. The useful thing about this tumor is that it stains with cytokeratin 20, which is unique amongst all the renal RCCs. And we have CK20. So it's a nice, simple stain to perform. It stains the cytoplasm and seems to also be staining the inclusions, but is negative in the nuclei. All right, so that's ending the part on kidney novelties. Now moving on to the prostate. So just to note that the 5th edition of WHO across all fields has moved away from using variants of tumor type and now refers to them as subtypes. Subtypes for a true subtype and patterns for just morphologic changes which don't have prognostic implications. And the reason for this is that the term variant is preferred to be restricted to molecular pathology, where a certain variant and mutation is detected. A novel nomenclature change includes dropping of the term basal cell carcinoma of the prostate and referring to it as adenoid cystic carcinoma of the prostate. And this is because it's identical in morphology and molecular aberrations to the salivary gland counterpart. So it still exists, it's still the same entity, it's just got a terminology change. And then importantly, prostatic intraepithelial neoplasia is now termed high-grade prostatic intraepithelial neoplasia. This is because low-grade PIN is thought to not exist. There's extremely poor inter-observer variability. And so now we only diagnose high-grade PIN. Importantly, the cribriform pattern of PIN is no longer considered a variant of PIN. PIN only includes flat, tufted, and solid types, micropapillary types, not a cribriform pattern. And that leads me into this concept of an atypical intraductal proliferation. This is not an entity, but it might be a descriptive term used in pathology reports to denote a spectrum of different lesions which fall short of a diagnosis of intraductal carcinoma of the prostate, which we will also be talking about. And I said that cribriform high-grade PIN is no longer recognized, and that's because it's moved across to this group of proliferations. And that's because there's increasing evidence that the clinical course and molecular features are near those of intraductal carcinoma of the prostate. Other terms that might be used in reports include atypical cribriform proliferation or atypical intraductal proliferation suspicious for intraductal carcinoma of the prostate. But importantly, this does not mean that the patient has intraductal carcinoma of the prostate. So what is intraductal carcinoma of the prostate? This is not a novel entity. It was recognized in the previous edition, but there are a few opposing schools of thought, and clarity hasn't necessarily been achieved yet. So this is a space that's going to evolve. So what is intraductal carcinoma? It encompasses two distinct entities. On the one hand, it truly is an in situ lesion, so a precursor lesion which is not yet invaded into the interstitium. And so this is thought to develop from high-grade PIN and precedes carcinoma. But this is extremely rare. It accounts for the minority of lesions in fact, the majority are actually the converse, where you have a high-grade invasive prostate cancer with a high burden. When I say prostate cancer, I'm referring to a prostatic acinar adenocarcinoma. It's a high grade and high burden, where you have extension of that invasive tumor up into the normal ducts with intraductal spread. So you're actually seeing tumor, but it's encased in a duct with retention of the basal layer. And that accounts for the majority of lesions. And it's fairly common in prostatectomies. We can see intraductal carcinoma in up to 30% of cases that coexist with high burden cancer, but it's extremely uncommon in those without cancer. So less than 1% of biopsies and radical prostatectomies will show intraductal carcinoma in the absence of invasive cancer. There are distinct morphologic criteria that we use for diagnosis. I won't go into that, but the implication is that it needs to be reported because the majority are associated with high-grade, high-burden disease. It needs to be noted in the pathology report. If there's no carcinoma in the core biopsies, then there is a need for repeat biopsy or imaging. And if it's truly pure, then definitive treatment should still be offered to the patient. It's also on its own a negative prognostic marker, often presenting with a higher grade burden of disease, extraprostatic extension, seminal vesicle invasion, and lymph node metastasis, and correlates strongly with biochemical recurrence, progression-free survival, and higher mortality rates. So if this is truly pure in a biopsy, then it's not going to be graded by the pathologist. This is agreed upon. However, the opposing schools of thought by the ISIP and GUPS is that, or whether one should incorporate it, if you have an invasive acinar adenocarcinoma in the background, should you incorporate this as a Gleason 4 cribriform morphology in the grading system? So the one school of thought, ISIP, is that you should, and GUPS is that you shouldn't. So that is out for the jury to decide, and hopefully in the next edition will be resolved. But essentially, we would need to apply basal markers to ensure that this is an invasive cribriform carcinoma, because that would need to be included regardless of your view in the final grading. And in the previous lecture, Dr. Pully mentioned prostate biopsy for BRCA2 mutated patients. So there is a recommendation by the NCCN that individuals who have intraductal carcinoma of the prostate or cribriform pattern of invasive prostatic acinar adenocarcinoma should actually be tested for BRCA2, but this has not yet been adopted by the WHO. All right, then just a brief word on acinar adenocarcinoma. There's no change in the existing subtypes, except for the addition of pin-like carcinoma. So pin-like carcinoma was previously grouped under ductal adenocarcinoma. It's now moved across, and we're going to talk about this on this slide. So the reason that it's moved across is that it's thought to more closely resemble prostatic acinar adenocarcinoma in both morphology and in behavior. It's got a favorable prognosis, similar to grade group 1 prostatic acinar adenocarcinomas, and is an important subtype to be aware of from our point of view because it can mimic high-grade pin or ductal adenocarcinoma, which are quite distinct entities. So briefly, a word on ductal adenocarcinoma, again, not a novel entity, but a word that it could be possibly be integrated into prostatic acinar adenocarcinoma in the future. And the reason for this is that they often co-occur, ductal and acinar adenocarcinoma, and they share clonal rearrangements such as ERG mutations. However, they do have a distinctive clinical behavior, and in that they often metastasize to lymph nodes, and the morphology in a lymph node might be quite different to that of acinar, and therefore might be difficult to diagnose from a pathology point of view. If a patient has a report of prior ductal adenocarcinoma in the prostate, it might be easier to diagnose metastasis than if it was lumped together with acinar. And the other reason is that they often, or not often, but they can occur in the transition zone and present with hematuria and urinary tract obstruction rather than occurring exclusively in the peripheral zone like the acinar adenocarcinoma. So for now, it stands as a distinct entity. Importantly, it's not a diagnosis we can make on a core needle biopsy. We can call it an adenocarcinoma with ductal features, However, the definitive diagnosis can only be made on a radical prostatectomy, and that's because there's an arbitrary cutoff of more than 50% ductal morphology for the diagnosis. So in the micrograph on the right, at the left, you can see what is a ductal adenocarcinoma with tall columnar cells, and on the right, we can see it coexisting with acinar adenocarcinoma. The Gleason grade, also known as ISIP or WHO grade, is unchanged. And there was a conference in 2019 with the IUCP and GUPS, which set out a whole number of recommendations on the right. However, these haven't yet been validated and are not yet included in the 5th edition WHO. But it is recommended that by the society and conference that we account for the percentage of Gleason 4 pattern in our Gleason grade group 2 and 3 biopsies. And in addition, if there's cribriform pattern, then we should mention that. And we should also mention that not only for grade groups 2 and 3, but also for grade group 4. But these haven't yet been adopted, but if you do see it in our reports, it's because we've adopted these recommendations on the right. And then there is this novel entity, which has been separated out from the neuroendocrine tumors of the prostate, which do exist, and the morphology and immunohistochemistry for the carcinomas is identical. The only difference with this entity is that there's preceding treatment with androgen receptor inhibitors, which drive a clonal proliferation of malignant cells with at least partial or complete neuroendocrine differentiation. And the importance of recognizing this entity is that the median survival is dismal. Patients have a survival of 12 months, and this typically presents within 24 months of therapy. And then very lastly on prostate, there have been a few molecular advances. So there's 4 different categories. The first 2 refer to DNA repair defects, which have therapy implications if present. So homologous recombination repair defects such as BRCA2 might respond to PARP inhibitors, and then Lynch syndrome could respond to immune checkpoint inhibitors. There's also an AR splice variant, which can be looked for in individuals who are going to be considered for second-generation androgen receptor antagonists that would predict a poor response to therapy, and therefore spare these patients undergoing therapy, which won't actually be suitable. And then lastly, there is an RNA-based genomic prostate classifier assay, but the utility of this is still being determined. It's costly, and it's applicable only to low and very low risk disease to guide management. So we don't have this available here. I think it's not yet been endorsed. All right, and then I did mention that intraductal carcinoma of the prostate and the cribriform patterns of adenocarcinoma are commonly associated with DNA repair genetic defects, and that the NCCN has recommended BRCA2 testing in these individuals. Okay, and then just lastly on the bladder, the histomorphology remains the gold standard here as well, although there is emerging molecular subclassification for muscle invasive and non-muscle invasive bladder tumors. Again, subtypes has replaced variants, with variants restricted to molecular. Urothelial papilloma and inverted papilloma are now included in the non-invasive urothelial neoplasm section as distinct entities. And they make a note just about PUNLUMP that some clinicians may, or pathologists may, choose to report this as PTA, but it's not to be confused with true PTA lesions, which are actually malignant, such as your non-invasive papillary carcinoma low grade. These have a low rate of recurrence and progression. So even if there is a staging PTA in the report, it does not mean that this is a carcinoma. And then importantly, they just note that invasive urothelial carcinoma should be graded. Traditionally, we know that invasive carcinomas are usually high grade, but there have been case reports of low grade invasive urothelial carcinomas, and these do have a better outcome. So it is important to grade all invasive carcinomas. Notably, the subtypes and the divergent differentiation carcinomas are all regarded as high grade. And if there is divergent differentiation, it should be quantified in the report. this is a novel distinguishing factor, which has been introduced into the 5th edition, and that is grading of heterogeneous neoplasms. So it's not always that easy just to call something low grade or high grade. There's often heterogeneity in the cytomorphology in up to 1/3 of cases. So when we see that the high grade component is more than 5% of the tumor burden, we will designate that as a high grade non-invasive urothelial papillary carcinoma. However, if it's less than 5%, you might see the report calling it a non-invasive papillary carcinoma low grade with less than 5% high grade component. And the reason for this is to try and generate standardized terminology to improve data generation so that we can better understand these lesions that have a minor high grade component, to see if the clinical implication is similar to pure high grade or high grade with more than 5%, or if it follows a clinical course more similar to low grade non-invasive lesions. Just a note on inverted tumors. Inverted urothelial papilloma is not the only inverted tumor. It can occur with all other groups of non-invasive urothelial lesions. And therefore, it's just important to be aware of. It's not common, but it might account for unusual cystoscopy findings. And then there are a number of precursor lesions which were previously recognized, which have now been dropped as distinct entities. So these terms might still be used in pathology reports, but they are not distinct entities. They include urothelial dysplasia, which is when one sees a atypia which does not meet the criteria for carcinoma in situ. And so this might still be used in a report, but it's not a distinct entity. And then your urothelial hyperplasia, either flat or papillary, are no longer recognized. They are thought to be shoulder lesions adjacent to a true PTA lesion, or an early non-invasive low-grade papillary carcinoma in the case of the tufted hyperplasia. But the term might still be used in difficult cases. Just important to know that they are not true, distinct biologic entities. And then in terms of the subtypes of urothelial tumors, not much has changed. There's just regrouping or moving of different entities apart from one another. So large nested is now recognized as its own subtype rather than being lumped with nested. Tubular has been removed from microcystic, and signet ring cell has been removed from plasmacytoid, and glycogen rich has been added to the clear cell subtype. And then there's been a lot of work on the molecular classification of bladder cancer. Over the years, we recognize that there are your low-grade non-muscle invasive tumors, which are characterized by aberrations such as fibroblast growth factor receptor 3 aberrations, and then you have your high-grade muscle invasive lesions, often developing from carcinoma in situ, which have TP53 mutations, retinoblastoma 1 mutations, etc. But over the years, there has been an emerging molecular classification for muscle invasive tumors, grouping tumors into 4 broad classes: stroma-rich, basal squamous, neuroendocrine, and luminal, with the luminal then being stratified into 3 different subtypes. And the importance for this is that each group of bladder cancer, from a molecular point of view, have different behaviors and respond to 2 different therapies. For example, your PD-1L inhibitors and so on. So also just to be aware of this is not the endpoint, it's still evolving. And so this might change in the next edition. And then almost at the end, these entities have been added to the WHO Blue Book as distinct entities. They include the Leiter gland, Skene gland, and Kalper gland adenocarcinomas. The Skene gland adenocarcinoma, the middle micrograph at the bottom, is analogous to prostatic adenocarcinoma, but occurring in females around the urethra in the Skene glands. And then bladder cytology, just a word we do use in our division, the Paris system for reporting cytology, and this is endorsed by the 5th edition of the WHO Blue Book. It's easy to use, it's available, and it's clinically relevant. We stratify the urology into one of these 5 classes, and they have a risk of high-grade malignancy, as you can see on the right column, correlating with each group. And we focus on diagnosing things as being high-grade. So either suspicious for or positive for high grade or negative for high grade, with 2 other groups also included. There is a limitation to this. We cannot stage the lesion. We cannot distinguish papillary and flat lesions, and it can undercore rare subtypes which are particularly bland, such as plasmacytoid subtype of urothelial carcinoma. It's also not a great system for distinguishing between low-grade lesions, and therefore we still rely on tumor resection for histology and imaging to improve staging of bladder cancer. And that's the end. Thank you.
Thanks a lot, Dr. De Stadler, for an excellent presentation, actually. We really quite enjoyed it, and I've had comments from colleagues sending me messages about the talk. There's a question from Dr. Goli from Port Elizabeth. Dr. Goli, you can go ahead and ask the question.
Thank you very much, Sam, and thank you so much to Dr. De Stadler. You know, I was very pleased that I could actually, as a urologist, keep up with all the talk and understand what she was saying. So really, really good talk. And I think I must also tell you that we don't have a permanent histopathologist here, and we won't call you a junior consultant here. If you come to Kabeja, I'm sure we'll be much more happier to have you. But what I really wanted to talk about is really the renal cell carcinoma. I mean, the changes are quite interesting. And I think they have an effect in terms of the follow-up, which is always kind of a problem once a patient's got RCC, you know. And I'm sure the changes now can influence that kind of follow-up, you know, especially with the new entities. So what I wanted to know is whether or not with the new descriptions of these entities in terms of renal cell carcinoma, whether you can diagnose this retrospectively. In other words, the tissue that is already there, are you able to stain for the various things that the new entities that we're talking about? Thanks.
Thank you very much. Yes, absolutely, we are able to. So we keep all of our slides and our wax blocks for a significant duration of time. The slides we don't keep forever, but the wax blocks which have the tissue embedded, we do keep in an archive, and that has been registered as a repository with the Division of Ethics. So one could do a retrospective study looking at renal cell carcinomas and trying to reclassify them according to the new classification system.
Yeah, thanks for that and the question. I just have 2 quick questions for you. Number one is papillary renal cell carcinoma, type 1, type 2. We've always known that type 2 is more aggressive. And the change in the fact that they've dropped the 2 different classifications now, is it more of a diagnostic thing histopathologically, or is it more of a prognosis thing? So that's the first question. The second one, I have very interesting concept you brought across with prostate biopsies, high-grade PIN with IDCP, intraductal carcinoma pattern, if I heard you correctly. And you did mention that, you know, because previously in high-grade PIN, like a solitary high-grade PIN, patients would usually just be followed up, PSA, rectal exams and everything else. And then multifocal, then those patients would sort of need to have a biopsy at 6 months. So this high-grade PIN with IDC pattern, to bring a lot of anxiety to us if we'd get that, because we always know that these cancers are quite aggressive. Is it something, because if you said if it comes back positive and pure, then we should treat. But if it's negative, we would still be quite anxious in sitting on a patient with an intraductal carcinoma pattern. I don't know if you've got any insights on that.
Thank you. Okay, I'll answer the second question first. So yeah, so high-grade PIN is not the same as intraductal carcinoma of the prostate. So for pure intraductal carcinoma of the prostate, we would recommend repeat biopsy and imaging, and then treatment, like you've said. But high-grade PIN on its own doesn't fall into the category of intraductal carcinoma of the prostate. It's just that the cribriform subtype is no longer recognized as high-grade PIN because it is more aligned with your your intraductal carcinoma of the prostate. And perhaps because of the anxiety related to just following those patients up, it's been moved, or it's been recommended that we rather group it under the atypical intraductal proliferations. So what that would mean for treatment, I'm not sure. I think the idea is that if we use better standardized terminology by recognizing high-grade PIN rather as atypical intraductal proliferations, we could get data that would then be able to guide management in the future. But what we do now, I'm not sure. Yeah. And then to answer the first question, yes, so traditionally, I think papillary RCC was divided into the two groups, and they did have different prognoses, but type 2 papillary RCC included a lot of entities that are more aggressive and that have molecular aberrations that are now recognized as distinctive entities. So the group has really, although it's still heterogeneous and it still includes lower grade and higher grade lesions, it's a narrower spectrum of entities, and therefore the prognosis should be similar. And that's why they don't recommend that we split it anymore into type 1 and type 2. They say that we can apply the WHO ISAP grading, nuclear grading, and that should give us a better idea of the aggressive nature of the lesion. But otherwise, as a group as a whole, the 5th edition says that they are considered to have a more favorable behavior than clear cell renal cell carcinoma as a group overall.
Yeah, no, thanks a lot for addressing those questions. We're really hoping not to get a lot of intraductal proliferations with our high-grade PINs. Okay. Would get very anxious with that, yeah. Up until we have evidence to suggest what we should do about it. But yeah, no, thanks a lot for an excellent talk. We really enjoyed the talk, and thanks again to Dr. Pule for a great start in our second semester. We hope to see the rest of the guys in the following week. Thanks a lot, Dr. Stadler.
Thank you.